We have recorded lecture of Professor Fukushima, which is first like a biography, am I right? A bit, and then a scientific one. So please let's see the recording, this lecture.
We'd like to thank Pablo Gonzalez for helping us in putting this together.
Professor Imato Kanan, members of the World Federation. I am Dr. Takanori Fukushima, the most senior active neurosurgeon in the world. Every day I work operating about 600 major cases a year. Most of my cases are for difficult and complex skull-base surgery. Thank you for inviting me to present my lecture on skull-base surgery. Over the past 30 years, I have been working very vigorously organizing skull-base hands-on dissection courses about 3 to 4 times a year. Microanatomy hands-on course is extremely important for younger neurosurgeons. They must take 10 to 20 times hands-on courses before attacking the complex skull-base tumors on actual patients. My lecture today is about the less invasive extradural lateral skull-base approaches. Professor, 4 decades ago, in 1980, in Japan, revolutionary changes started from conventional intradural microneurosurgery to the extradural skull-base surgery. Lateral skull-base surgery has been the most important in extradural skull-base surgery. Various innovative approaches were developed in terms of less invasive brain, nerves, and vessels protection. There are 10 different extradural approaches in lateral skull-base surgery. Anterior lateral subfrontal approach, anterior lateral orbital approach, supinoclinoidal approach, extradural transcavernous sinus surgery, extradural subtemporal ester transrhomboid approach, anterior and middle infratemporal fossa approach, namely AITF and MITF, combined petrosal approach, various kinds of transmastoid exposure, jugular foramen approach, and elite transcondylar skull-base approach. To perform skull-base surgery efficiently with success, one of the most important issues is the use of advanced refined micro-instruments. The number one important is the teardrop side port tapered suctions. The surgeon needs 20 to 30 pieces of different sizes and lengths. The number two important is the use of 3 major non-stick bipolar forceps, Silverglide, Vesalius, and Tokyo Fujita micro bipolars of different tip sizes, 0.15, 0.2, 0.25, and 0.3 of various angled tips and lengths, 20 to 30 pieces of bayonet bipolar forceps. The number 3 important is the use of 20 to 30 micro scissors, thin blade, medium blade, rigid thick blade with straight, slightly curved, more curved tips, and of various lengths, short, medium, long, extra long bayonet micro scissors. In this presentation, Fukushima will demonstrate one case of direct cavernous sinus surgery with petro-clival clearance and two cases of combined petrosal approach. In early 1980s, Fukushima's challenge for direct transcavernous sinus surgery had significant influence and benefit from Professors Hakuba and Dorrance. In 1986, Fukushima published the world's first illustration of the triangular scheme of the entry corridor into the cavernous sinus, later more elaborated in 1991 publication. Fukushima developed the new concept of less invasive transcranial infratemporal fossa approach, AITF and MITF, in 1990, improving the extensive and aggressive exposure of fish infratemporal fossa approaches. V2 and V3 panoramic lateral Vidian triangle exposure for AITF. Fukushima operated more than 100 cases of various infratemporal fossa regions. Meningiomas, schwannomas, juvenile angiofibromas, ameroblastomas, epigonatus, and so forth. Extradural subtemporal middle fossa approach, ESTA, is one of the most frequently used in lateral skull base surgery. In 1992, Fukushima developed the concept of the middle fossa rhomboid while operating the posterior transcavernous approach. In 1986, Fukushima named the posterolateral triangle of the cavernous sinus as Glasscock and the posteromedial triangle as Kawase. The trigeminal third branch anterior translocation has been often used to make access to the infracavernous petrous apex region. The combined petrosal approach was developed in Japan by core members of the Japan Neurosurgical Society, including Fukushima, and utilized for radical surgery of large petro-clival meningiomas, giant-sized schwannomas, epidermoids, giant cell tumors, chordomas, and so on. Patient positioning is very important, either in lateral or supine heterolateral position. Lumbar spinal CSF drainage and harvest of abdominal fascia and fatty tissue are standard. Pre-auricular chef-hat incision, 3-layer elevation of the soft tissue, skin flap with STA frontal branch attached, gyrofacial STA parietal branch attached, wide pedicled, highly vascularized flap, and muscle layers. Understanding of the bony landmarks and the mastoid triangles are the key elements of the combined petrosal craniotomy. At first, the mastoid needs to be skeletonized, either retrolabyrinthine or translabyrinthine. Next, a long L-shaped bone flap is turned, including anterior, middle, posterior, temporal, occipital, and suboccipital, using only diamonds and craniotome for minimal bone loss. We never use a big perforator. The dural incision must be only curvilinear, no incision over the vein of Labé. The most important technique in the combined petrosal approach is the detachment and resection of the rhomboid-shaped tentorium. 60-year-old female with very large petro-clival meningioma, total resection with fat graft, no deficit. 65-year-old gentleman with dumbbell-shaped large petro-clival meningioma, total resection has been performed without any complication. 14-year-old young pediatric large petro-clival meningioma, total resection through the combined petrosal approach. No radiation. 10 years of follow-up showed no recurrence. She got married and had children. 50-year-old lady with mega giant petro-clival meningioma, total resection with hearing preservation, no deficit. 24-year-old young man admitted on wheelchair with quadriparesis and ataxia. Total resection of the tumor through the combined petrosal approach. He recovered to the normal functioning status, no deficit, and working. Now, video, please.
Enhanced MRI demonstrates a 4 by 5 centimeter size large petro-clival meningioma, which is engulfing the vertebral basilar artery. Through a standard combined petrosal approach, the patient is placed in the right side of lateral position. And now this is a right side of the external ear canal, superior point. Here is a root of zygoma, spine of Henry, and we have already performed the retrolabyrinthine mastoidectomy and extended the middle fossa approach. This is the completion of the combined petrosal exposure skull-base drill, entirely no bones, pre-sigmoid to the jugular bone. Now I open the subtemporal pre-sigmoid. As usual, I'm starting from the backside posteriorly at the junction of the sigmoid transverse sinus. And then now I am incising the tentorium in the posterior side. This tentorium looks no meningioma invasions. And in the depths, I see a big meningioma here. And then I follow anteriorly along the tentorial edge. And I see here the carotid and then oculomotor nerve. And fortunately, oculomotor nerve, the fourth nerve dissections. And this is a posterior cerebral. So I will start from the fourth nerve and posterior cerebral artery dissection. Now I am dissecting the fourth nerve off from this fourth nerve sharply with micro scissors and knife. Following the subtemporal ABR, good facial nerve response, and the 5. I am going in the depths between the 7 and 8 and 5. And then I'm pulling all these. Now there are, I find the 6th nerve dissected, and I found all nerves. Only the thing is a vertebral-basilar now. Then I separate the abducens. Give me a gel form, please. Now I am opening the Meckel's cave entrance of the trigeminal. Now I opened the Meckel's cave, and this patient is very fortunate. There is no invasion. This meningioma, large meningioma using a QSA. I am now going very effectively to the petro-clival origin. And I already separated and this is the elevation of the trigeminal nerve. And I am separating everything from the clivus. And now this, again, using a Olympus ultrasonic aspirator, I am now more decompressing the tumor. Now this is tumor capsule. I am separating sharply. This is the final separation of the main trunk of the SCA. I am getting the last portion of this tumor chunk. The superior cerebella here. It's a main trunk of superior cerebella engulfed in the tumor. Give me a micro scissors. This is a most adherent portion of this tumor with the micro scissors. It's a very fibrous adhesion with the pons. And I have to see the very, very carefully the dissection point. Patient is a 40 years old young lady. I want to make a total resection. This is the last bit of the, I have to separate sharply. Now I have separated the basilar artery. It was a very, very severe adhesion of brainstem and tumor capsule. And this side is also the pontomesencephalic junction. And then this is the last piece of tumor. And finally, this tumor I removed in a total fashion. A 6-year-old woman who presented with a 1-week period of acutely progressing headache, nausea, vomiting, and ataxia. The patient has a very large, high geographic rootlets. This is the ligation of the superior petrosal sinus. And then you see here now, this is the trigeminal nerve root and the tumor, but relatively soft and suckable. You see here now. Now this is the fibrous ring of the trigeminal nerve root. Can separate from the rootlets. Over the tumor, this is the 4th nerve, and using the 11 blade knife, then I cut the tunnel division using a monopolar cautery, a micro scissors straight. I found here the 7 and 8, extremely stretched. 7 and 8, you see here now. Now I have the arachnoid dissection plane, right abducens nerve in the tumor, and I am following the dissection plane with micro scissors. in a hypothalamus and the pituitary stalk. This is the last piece of the meningioma capsule adhesion to the pons, upper pons. After 12 hours of meticulous microsurgery, I finally resected this entirely with this combined petrocell approach.
It's done.
Pablo, that was all? I suppose.
That's it.
That's it. All right. Thank you very much. That was very nice. And let's say that it was something we all should see.